Thank you for joining my presentation on volume guarantee ventilation for the neonates. My name is Terrence Shenfield, and I've been an education coordinator at a major trauma center in Newark, New Jersey. I am also the co-owner of A&T Respiratory Lectures. At the end of this lecture, you'll understand everything about volume guarantee, or also they call this volume targeted ventilation. In today's objectives, we're going to be talking about why is ventilating neonates a problem? What kind of things can impact the ventilation of neonates? We'll also be talking about the difference between volume-controlled ventilation versus pressure-controlled ventilation. We're going to talk about the advantages and disadvantages of each types of ventilation. Then we're going to talk about what is volume guarantee ventilation and how does it work. Another word for volume guarantee ventilation is volume targeted ventilation. Then I'm going to talk about some of the potential advantages of using this type of mode with the neonate population. By the end of this presentation, you're going to have a good handle on these topics. So let's get a little bit more into tidal volumes for babies. In neonates, the average tidal volume is anywhere from 4 to 6 milliliters per kilogram. Anatomic dead space is roughly 3.3 milliliters per kilogram. Because these babies are so small, you can imagine that it becomes pretty even. Tidal volume is pretty close to dead space. So the problem with conventional ventilation is that when the tidal volume is less than or close to total dead space, this normally produces insufficient gas exchange in the alveolar. No matter what respiratory rate you have, no matter what minute ventilation you have, you're going to have a problem with ventilation with these babies with these small tidal volumes. Also, small tidal volumes also lead to progressive atelectasis. It actually results in ventilation perfusion mismatching and ultimately impaired oxygenation. So getting your tidal volumes correct on these patients is really, really important. And that's why we're going to talk more about delivery of tidal volumes as we move along. There's a host of other problems that's associated with tidal volumes, such as volume-associated lung injury. The baby's lungs are very fragile, and the alveolar units cannot really take powerful distending pressures down into the alveolar. A lot of times these babies, if they're overly distended, end up getting what is known as ventilator-associated lung injury. Ventilator-associated lung injury has two subparts to it. One is called electrotrauma, and the other one is called barotrauma. Barotrauma is caused when the lung injury is caused by high transpulmonary pressures, where electrotrauma is caused by the opening and closing of collapsed alveola. Both of these conditions can lead to pulmonary interstitial emphysema, pneumothoraces, as well as air leak syndromes. So delivering the right tidal volume to these babies is really important, as I stress some of the components that can go wrong when you overly distend the airway. So in summary, why should we be caring about tidal volumes? Number one, these babies are so small that their tidal volume sometimes equates to dead space. So if you don't ventilate them properly, this could produce insufficient exchange of alveolar gases, leading to hypoxemia as well as hypercapnia. Number two, large tidal volumes can produce alveolar and airway overdistension and actually result in barotrauma or electrotrauma. And number three, if you overstretch the lung and you overdistend the lung, this could cause further lung injury, such as pneumothoraces. So you really got to understand that giving the correct tidal volume is ultimately important for the survivability of these babies. Another problem with ventilating a neonate is the endotracheal tube. Typically, endotracheal tubes for neonates are cuffless. So what does that mean? That means that there is leaks coming around the endotracheal tube, that the delivered tidal volume may not be exactly what you expect. And this all depends on the inspiratory pressure being delivered to the patient. It could also depend on the position of the patient if the patient is in a supine position versus on the side. So all of these things can impact the tidal volume delivery to the patient. So uncuffed endotracheal tubes, which is commonplace in the neonate population, can sometimes be a problem if you don't know how to monitor exhale tidal volumes coming back as a result of the delivery of those tidal volumes. So let's talk about one more problem with ventilating the neonate, and that has to do with compliance. Typically, the compliance of a neonate all depends if they have respiratory distress syndrome or if they have any other kind of lung disorder. Poor compliance of the infant is a problem when you compare the compliance of the ventilator circuit. These tidal volumes that are being delivered are so small that, and the compliance of the circuits could sometimes be high. So sometimes delivering the correct tidal volume or the correct pressure is a real challenge, especially with some ventilators. So another concern for tidal volume delivery is the compliance of the lung versus the compliance of the circuit. And a lot of ventilators have compensation methods to determine the compliance of the circuit, but sometimes when you deliver such small tidal volumes, they're not completely accurate. So this is another reason why you really want to monitor the tidal volumes being delivered to the patient. So let's talk about some of the basic settings for volume-controlled ventilation. There are some advantages of volume-controlled ventilation. First of all, the clinician would normally set the tidal volume at a fixed rate of anywhere 4 to 6 milliliters per kilogram on the average. Their typical rate could be anywhere from 40 to 60 breaths per minute. Sometimes it could be lower, but most of the time it's within this range for the neonates. Inspiratory time is anywhere from 0.3 to 0.5 seconds. PEEP, typically we start with a lower level of PEEP, but we could go to higher levels of PEEP if the requirement for oxygen is higher. FiO2 is anywhere from 40 to 100%, depending on the clinical situation. Sometimes it could even be lower. And a very important factor is determination of inspiration is affected by the preset tidal volume being delivered or by the maximal inspiratory time being elapsed. So this is how this is pressure limited to a certain extent. Another way to monitor the pressures being delivered with volume control limit is to set a high pressure limit. So if you're delivering a tidal volume and the inspiratory pressure to deliver that tidal volume is very high, the pressure limit will lower that, resulting in a lower tidal volume being delivered to the patient. That talks a little bit about the disadvantage of volume control ventilation, which I'm going to get a little bit more into. But these are some basic settings you need to set up a ventilator. As with anything in life, there are advantages and disadvantages. In regard to volume control ventilation, there are some advantages and there are some disadvantages. The most significant advantage of using volume control ventilation has to do with the fact that patients' lung compliance may change from moment to moment. I don't mean from split second to split second, but if someone's disease condition gets worse, their compliance can get worse, or if someone gets surfactant therapy, that would change their compliance too. No matter what, if you have a set tidal volume based upon their ideal body weight, then they would get a tidal volume that is appropriate for them. So that is one of the major advantages. No matter what the compliance of the lung is, or no matter what kind of postural change you're in, you're going to get a constant tidal volume. Also, another advantage is that the clinician could set the parameters on a ventilator prior to the patient going on. So in other words, you have a baby, it's born, has a certain weight, and then based upon that weight, you can set some ventilator parameters set up and put the baby on a ventilator, which makes it rather simple to be set up. One of the disadvantages, and this is a major disadvantage of volume control ventilation, is if compliance in the lung really worsens bad and you start delivering higher tidal volumes, or that the tidal volume being delivered actually causes lung overdistension, this can cause barotrauma. So one of the major disadvantages of volume-controlled ventilation is barotrauma resulting from changes in compliance. Or the patient can be underventilated if it pressure limits at a certain time. So these are some of the advantages, some of the disadvantages of basic volume control ventilation. Now let's turn our attention to pressure-limited controlled ventilation, sometimes called time-cycled pressure-limited ventilation, or commonly known as TCPL. The flow with this particular pressure-limited systems can either be variable or constant, all depends on the mode. The actual tidal volume delivered can depend on the driving pressures of the ventilator, can depend on the pulmonary mechanics such as compliance and resistance, and can also depend on spontaneous effort. So what does that mean? That means you can have great variability in your tidal volume with this particular mode of ventilation. The advantages of this is, since you are pressure limited, you will reduce the risk of barotrauma, so you probably will not overdistend the airway. The flip side to that is, if you don't distend the airway, you may not remove CO2, or you might create situations where you're either hypocapnic or hypercapnic. So because of variations in the driving pressure, sometimes you may not get exactly what you want from it. Another advantage of pressure-limited control ventilation is that it's less influenced by leaks, like volume cycle ventilation. What does that mean is, when you have a volume cycle ventilator and there's a leak, a cuffless endotracheal tube, a lot of the volume can escape around the endotracheal tube. But with pressure-limited ventilation, they are looking to maintain a certain pressure. So even though you have a leak, it's still going to try to have enough driving pressure to give you, to compensate for that leak, to give you the pressure you want. So these are the two types of modes. You have pressure limited, you have volume cycle ventilation, and somehow they have advantages and disadvantages, but that's where volume targeted ventilation comes into play. Volume guaranteed ventilation comes into play. It's basically a hybrid of the two, and it actually is the best of both worlds. So from this point on, now that I covered some basic mechanical ventilation strategies, now we're going to get into the topic at hand. So when you use pressure limited ventilation, what typical peak airway pressure would you use for a new admission? So that could be a difficult decision. If you're not using a tidal volume breath, you're going to be looking at some pressure that would inflate the lung appropriately. So basically, you have to pick a pressure, and then you have to watch for chest movement, and then adjust the pressure based on blood gases. Basically, PIP is determined by adequate chest wall movement. So if you see the chest wall rise, you could assume that you're giving an appropriate PIP level. Some ballpark figures are, if you have an infant weighing less than 1,500 grams, typically your PIP has to be anywhere from 16 to 28 centimeters of water. And if the baby is greater than 1,500 grams, typically it's around 20 to 30 centimeters of water. The problem with pressure control ventilation is that a set pressure that you set at one moment to give you a certain return tidal volume or a certain chest rise can change over time as the compliance and the resistance of the lung changes. So this is the real big problem with pressure limited ventilation, is that based on compliance, based on resistance, you could see changes. Another problem is the leak that occurs around the endotracheal tube. So you really don't have a good idea what's going on. So to approach this problem and try to fix it, modern neonatal ventilations needs to target the expired tidal volume and not the peak inspiratory pressures. This is the whole premise of volume targeted ventilation, that you don't necessarily look at the PIP, but what you look at is your exhale tidal volumes that come out of the lung. So we're going to get a little bit more into this. I gave you some background information to start with, and now we're going to move on to volume targeted ventilation. So now that we know some basic ventilation strategies, how do you control oxygen? How do you ensure that a baby doesn't become hypoxic? So one of the key things is that controlling of oxygen does not necessarily mean that you have to move in and out gas into the lung. It's not really controlled by tidal volume. How it is controlled is that if you have enough oxygen in your lung that it could diffuse into your blood, and that is the basis of oxygenation. So if the baby is hypoxic, you have a couple of choices. You don't increase the tidal volume. What you do is you increase the FiO2, or you use an open lung approach, such as using PEEP or CPAP, or increasing the mean airway pressure. Mean airway pressure is significant for oxygenation. So these are some basic controls for oxygen status, and then I'm going to tell you a little bit about ventilation status on the next slide. So let's now talk about how to control CO2. Basically, when you have a problem with CO2, this is directly impacted by the movement of gas in and out of the lungs to remove CO2. You need tidal volume to remove CO2. You also have the ability to increase the respiratory rate or increase the spontaneous breathing rate, maybe with a little pressure support if needed. Also, if you have a patient who is hypercarbia or hypocarbia, the way to make the adjustment is to first adjust the tidal volume and then alter the respiratory rate. These are some of the fixes for controlling of CO2 in the lung, which is different than the oxygenation status I just mentioned before. We have come a long way in mechanical ventilation. When I first started in 1992, we used to use the birds up in our NICU. Over the years, we have come up with some new ventilator purchases. We ended up getting the Baby Log by Draeger. But any of these new ventilators we have today for the NICU can accurately measure inspired tidal volume, expired tidal volume, endotracheal tube leaks. They have ways of measuring inflation, inspiration, expiration times, and pressures. And with all that being said, if you have all of these tools, should we be using tidal volume breaths or pressure limited ventilation? Is that good enough? Is that the right way to set? The problem with that, a set PIP cannot deliver a set tidal volume, because when the baby breathes or cries or goes apneic or compliance changes of the baby occur, that will change the tidal volume. So when you really think about it, when you use pressure control ventilation for the neonates, that can create problems based upon the baby's condition. And because our new end ventilators can be so accurate in measuring tidal volumes, especially expired tidal volumes, we should think about a new mode of ventilation for them, and they already have that, and it's been out for a number of years. So what exactly is volume guarantee ventilation? Volume guarantee ventilation is a term used by Draeger Medical. Also, there are different terminologies for volume targeted ventilation. So when I use the word volume guarantee or volume targeted, I am using it interchangeably. It's basically the same thing. There is some slight nuances between each type, and I'll get a little bit more into that later, but I just want you to say when I use volume guarantee and I'm saying volume targeted, I mean the same thing. So we talked about the disadvantages of volume control ventilation in the fact that due to the circuit compression, due to the leaks, due to the small tidal volumes that these babies get, it can be a real problem for them. So in regard to volume targeted ventilation, Basically what it does, it aims to deliver a consistent tidal volume, breath after breath after breath. And different ventilators have different names for particularly volume targeted ventilation or volume guarantee. And basically these ventilators are modified and have special algorithms that can adjust one or more of these parameters. It can adjust the PIP, it can adjust the inflation time, and it can actually adjust the inflation flow. So due to the different combinations of these, this is how it works. Basically, a clinician sets a targeted tidal volume they want to deliver to the baby. And also, these ventilators measure the inspiratory tidal volume. They measure the expiratory tidal volume. Why expiratory? Because of leaks, because of compliance issues. And then, based upon what goes in and what comes out, it will make an adjustment to the tidal volume breath by breath. Expired tidal volume is less affected by endotracheal tube leaks. So what happens is with volume guarantee ventilation, the ventilator assumes the patient has a leak breath by breath, and then it will make adjustments to that leak to deliver a better tidal volume which matches what they want to do. So the concept of volume guaranteed ventilation is it actually adjusts for leaks, for compliance, circuit compliance issues, and it does this on a breath by breath issue, and it also will deliver an exact tidal volume breath by breath by breath. So these are the real benefits of volume guarantee ventilation, where pressure control ventilation doesn't do this. Also, at the same time, volume cycle ventilation doesn't do this either. So only volume guarantee ventilation or volume targeted ventilation. And as I told you, these are different names by different manufacturers, and I'm going to get a little bit more into that. But that is how the basics of volume guarantee. They look at inspiratory tidal volume, they look at expiratory tidal volume, they look at leaks, they look at compliance, and based upon that, they have a computer algorithm that will reset the tidal volume breath by breath to ensure that the patient gets the proper tidal volume, even though they have a leak, even though there's a compliance issue, and so on. What that does, it stabilizes the ventilation of the patient, and you can more or less have a better blood gas. So there are many reasons why a volume being delivered to the patient is not exact, and especially with the neonate population. That is another reason why you want some kind of volume guaranteed or volume targeted ventilation with the babies. For example, if the baby is breathing asynchronous with the vent, that will impact tidal volume breaths. If the baby's crying, that's another reason why the tidal volume may not be delivered. If the baby's splinting the abdomen or the diaphragm, that can obstruct inflations. If the patient goes apneic, of course that can impact tidal volumes. Compliance and resistance changes in the lung can impact tidal volumes. Surfactant treatment. If the patient gets surfactant, you obviously are going to get better compliance, and then tidal volumes will change. And also, very importantly, endotracheal tube leaks. As we said before, babies have cuffless endotracheal tubes, so the bigger the leak, different positions, so on, result in asynchronous tidal volumes being delivered to the patient. For all of these reasons, that is why you need to come up with a better strategy for delivering good breaths to a patient. Let's get a little bit deeper into how each of these modes work on different types of ventilator. All of these modes are volume-targeted ventilation. And for example, PRVC, pressure-regulated volume control. It's offered on the Servo 300 and the Servo I, which is based on Metcalf Critical Care in Bridgewater, New Jersey. And how this works is each breath starts as a pressure-limited breath, but if they have a set tidal volume, it's not reached. The breath converts to a flow cycle mode by prolonging the inspiratory time with a passive increase in PIP. So basically, if the tidal volume is not reached due to whatever reason, the device automatically switches over to a float cycle mode and works by prolonging the inspiratory time, and this will increase the PIP, actually delivering the tidal volume that's necessary. The next mode of ventilation is called VAPS, VAPS, and that's Volume Assured Pressure Support. That is offered by the Bird ventilator. It's basic from Viasis Healthcare, and actually it works on the same exact way as PRVC. And then finally, we get volume guarantee ventilation, which is done by the Baby Log, which is Dräger Medical in Germany. And they have a different way of looking at it. Basically, they look at inspiratory tidal volumes, expiratory tidal volumes, and because of the leak, the device automatically compensates for that leak by delivering an increase in pressure or flow to meet the tidal volume which is necessary. So PRVC, VAPS work by the same mode. Dräger ventilators, which the Dräger Baby Log, actually works by a different way by measuring inspiratory tidal volumes, expiratory tidal volumes, and then computer algorithms make adjustments with flow and pressure to meet that targeted tidal volume. So this is a quick and dirty way of looking at each of these ventilators. Each of them roughly do the same thing. Each of them have their own particular word versus volume guarantee or volume targeted ventilation, but the strategy is the same and the outcomes are the same. The patients do very well. Is any ventilator better than the other? I don't think so. I think what's really important is the clinician who works them. So I'm not here to endorse any particular ventilator, but I'm here to say what each ventilator offers. Let's talk about the three modes that we mentioned. We'll go a little bit deeper into it. Let's first start off with PRVC, Pressure Regulated Volume Control. So basically, this is a pressure-limited, time-cycled mode that adjusts the inspiratory pressure to meet a target tidal volume. So basically, you set a target tidal volume, and the ventilator will automatically adjust the inspiratory pressure to reach that tidal volume. And it really it does this breath by breath, so any kind of changes in compliance or leak will be met with an increase in inspiratory pressure or a decrease. The main problem with this is that these measurements are measured at the ventilator rather than at the Y. And some of the problems with that is sometimes when these measurements are so far away from the patient's Y, they're inaccurate. Also, a lot of times these patients have inadequate PIPs because of the leak. So because there's a significant leak in the cuff, they don't adjust it properly. So, and also there's a loss of volume in the circuit. Like we said before, the compliance of the circuit and the compliance of the patient and the small tidal volumes make it very difficult. So see, these are some of the limitations of PRVC. So let's talk about volume assured pressure support, otherwise known as VAPS. Basically, this is a hybrid mode, and each breath starts as a pressure limited breath. So you have a set tidal volume looking to reach. It starts off as a pressure limited breath. If that tidal volume is not reached, the ventilator automatically converts to a flow cycled mode by prolonging the inspiratory time. So let's think about this. So if you don't reach the tidal volume that you targeted, it increases the inspiratory time or I time with flow in order to meet that tidal volume. The problem with that is kind of self-evident. The longer you have an I time, the less time for exhalation, which could cause asynchronous breathing with the ventilator. Also, these tidal volumes are kind of iffy in the significant presence of a big leak. Also, there's no provision for automatically lowering the inspiratory pressure as lung compliance improves. They did something about this, though. The new Avia ventilator by Viasis added a special feature called volume limit function. Basically, when a tidal volume is reached, it will automatically shut off so it doesn't overly distend the lung. That's a safety feature, which is a good one. So this is another type of volume targeted breath, and it's called VAPS. Our final ventilator we're going to go over that offers volume guarantee or volume targeted breath is the Draeger Babylog. Volume guarantee option regulates inspiratory pressure using exhale tidal volume measurements. So the benefit of the Draeger ventilator, it measures your exhale tidal volumes rather than your inspiratory tidal volumes. So basically it's more accurate when you have a leak. So because if you have a leak and you measure your exhale tidal volumes, that's more accurate than using the inspiratory tidal volume that goes in. So the clinician will target a tidal volume and then actually sets a pressure limit. Well, like, what is the highest pressure you want to go? This is a lung protective strategy. So basically a computer algorithm in the system measures breath by breath of exhale tidal volumes and then makes adjustments to the peak inspiratory pressure to meet those tidal volumes. There is some advantages to this mode. For example, you could use this as an automatic weaning mode. So if you put volume guarantee on a patient, and you could just let this thing go and it could wean the patient from the ventilator automatically because it will lower the peak inspiratory pressures each time as they breathe better and better on their own. There are some drawbacks. Some of the drawbacks is that rapid changes in compliance will not be met with a good tidal volume because it takes a few breaths for the algorithm to pick up what's the exact peak inspiratory pressure to deliver. So sometimes it's slow to act in the need of a patient's needs if, as their compliance changes. But this is the third, and I'm sure there are other modes of ventilation on other ventilators that I'm not covering, but I wanted to get into the point of understanding what it is. So I wanted to get into some of the studies that support the use of volume-targeted ventilation or volume-guaranteed ventilation versus pressure-limited ventilation in the neonates. And a good place to start is with the Cochrane Library. I don't know if you know much about the Cochrane Library. The Cochrane Library is basically an organization that reviews all systematic reviews of many different studies out there. So what they do is they look at multiple studies on the use of volume-targeted ventilation versus pressure-limited ventilation in the neonates, and then they come up with a consensus of does it work or does it not work. And this is sometimes, if you ever have a question in regard to some kind of modality, always go to the Cochrane Library because it really gives you some really good information on where to find some good evidence. So let's talk about this. So they did a study, it's from 2010, and they looked at volume-targeted versus pressure-limited ventilation in a neonate, and I'll give you the results of that study. So in this Cochrane review from 2010, they asked this question: does ventilator therapy of infants using a strategy targeting inflation volume rather than inflation targeting pressure lead to lower rates of death or damage to the infants? So basically they wanted to know if you target a tidal volume versus targeting a pressure, which one had a better outcome for the patient. And here are the results. The babies who were ventilated using volume-targeted modes of ventilation were more likely to survive free of any kind of lung damage versus the pressure-limited group. They needed ventilator assistance for a shorter duration and were less likely to develop a pneumothorax. So think of that. So first of all, the survivability was better. There was less duration on mechanical ventilation. They were less likely to develop a pneumothorax. They had more stable CO2 levels in the blood and had fewer brain ultrasound abnormalities. Another big plus. There was no evidence that volume-targeted modes were more likely to harm the infant than traditional pressure-limited modes. So what you're saying here is that the babies come off the ventilator quicker, they survive better, there is less likely to develop a pneumothorax, their CO2 levels were better, they had fewer brain ultrasound abnormalities. So all of these are positive things. Of course, they have to say a statement like more research is needed to understand whether volume-targeted modes can also lead to improvements in the development of movement and intellect. And they also need more research on comparing different volume targeting techniques. So the bottom line is the Cochrane study, which looked at multitude of different studies on volume targeted ventilation, came up with thumbs up on so many different categories versus pressure limited ventilation. This is a big reason why you should be using it. Now I'm going to get into some studies to support the use of volume guarantee or volume targeted ventilation. And there are numerous studies and the evidence is overwhelmingly positive. So let me show you the evidence. So before I was telling you about a study from Cochrane where they were looking at volume targeted versus pressure limited ventilation. And this was done by a study group of Wheeler et al. And I wanted to show you that he redid the study from 2010 to 2017. And this was a systematic review and a meta-analysis where they looked at volume-targeted versus pressure-limited ventilation for preterm infants. It was a systematic review and meta-analysis. And I'll go over the findings during that study. Remember, this is a repeat of the 2010 study, so they were looking at new data that came in from 2010 to 2017. And the question they asked, this was the question they did research on. Does ventilator therapy of infants using a strategy of targeting inflation volume rather than inflation pressure lead to lower rates of death or lung damage or both among infants? So basically, they were asking the strategy of volume targeted ventilation versus pressure ventilation and see which one had less damage to the infant. And again, this was published from Cochrane Review from October 2017, and it was done by the same study group. The findings from this study was that babies ventilated using volume-targeted modes of ventilation were more likely to survive and be free of lung damage. So that was the first finding. They needed ventilator assistance for a shorter duration and were less likely to develop a pneumothorax. So they would have spent less time on the vent and they didn't develop as many pneumothoraxes. They also were more stable CO2 levels in their blood and had fewer brain ultrasound abnormalities. So the key findings here was that volume-targeted ventilation was superior to pressure control ventilation in these things. Also, they, like with all studies, they say that they really need to do more research, and they will do more research because I got more studies coming out after I finish this one. But the key point here, it really did work well as a review in Cochrane, and this was a re-review from 2010 to 2017, and again, the evidence supports the use of volume-targeted ventilation. So in conclusion, the use of volume-targeted ventilation was associated with some very important clinical benefits. Number one, reductions in combined outcomes of death, BPD, incidence of hypocarbia, pneumothoraces, duration of mechanical ventilation, and they had less severe IVH. So these are some significant benefits. Also, volume-targeted ventilation was not associated with any increase in adverse outcomes. So basically, it showed to be a superior mode of ventilation versus pressure control ventilation for the neonates. This is one study, and I have more to follow. This was a second study done by Wang, Shang, Peng, and team. They looked at volume-targeted ventilation is more suitable than pressure-limited ventilation for preterm infants. Again, they did a systematic review and meta-analysis. So this was a study from China where they looked similar. Is volume-targeted ventilation more suitable than pressure-limited ventilation? And we'll go into the findings. So during their research on this, the objective was to assess the effect of volume-targeted ventilation compared with pressure-limited ventilation in preterm infants. And they searched the Cochrane Library, PubMed, China National Knowledge Infrastructure, and other databases. Then what they were really looking for, which is good, is they looked for selected randomized controlled trials and quasi-randomized controlled trials of comparing volume-targeted ventilation versus pressure-limited ventilation. And then they performed a meta-analysis with some statistical software. So this is a very valid test on determining which mode of ventilation is better. The findings from these studies was pretty significant. They found that preterm infants ventilated using volume-targeted ventilation versus pressure-limited ventilation had a decrease in duration of mechanical ventilation. That means they were off the ventilator quicker. The decreased incidence of bronchopulmonary dysplasia. They also showed a decrease in failure of ventilation mode. So in other words, once you put the baby on volume-targeted ventilation, they did not fail in that mode. They also had reduced cases of hypocarbia, and they also had reduced cases of IVH grade 3 and 4, and they also had reduced cases of pneumothorax. The only caveat they had was that the death rate was the same. So the point is this, the same amount of infants died in each type of mode of ventilation, but the benefit was all which I listed above, which is significant. So the findings from these studies were really positive for the use of volume-targeted ventilation. So another study they did is called volume guarantee ventilation in neonates treated with hypothermia for hypoxic ischemic encephalopathy during interhospital transport. That's a mouthful. Basically, I wanted to give you a little background. We all know what hypothermia is and where they lower the body temperature, but you might not know what hypoxic ischemic encephalopathy is. Basically, HIE is one of the most serious birth complications affecting neonates. It occurs anywhere from 1.5 to 2.5 per 1,000 live births in most developed countries. It's basically a brain injury that prevents adequate blood flow to the brain of the child. And this is a result of a hypoxic ischemic event during birth. By the age of 2 years of age, 60% of these infants will die, and if they don't die, they have severe disabilities, including mental retardation, epilepsy, and cerebral palsy. So I'm going to get a little bit more into this, but controlling CO2 is so important with this population. And they believe that volume guarantee ventilation in this particular segment of patients is really important, especially when you do any kind of hospital transport. So this is what this study is based on. So the objective of this study was they investigated if volume guarantee ventilation in babies with hypoxic ischemic encephalopathy, HIE, during interhospital transport decreases tidal volumes and prevents hypocapnia. So the goal with these patients is to prevent hypocapnia. You don't want to blow off all the CO2. And let me give you a little background with this. Both pH and PCO2 affect vascular tone and cerebral blood flow, cerebral oxygenation, and thereby can modulate brain injury in neonates with HIE. Experimental evidence suggests that low PCO2 concentrations mediated by hyperventilation in brain-injured patients may restore cerebral autoregulation and compensate for metabolic acidosis, thus preventing further damage. So the goal is to control the tidal volumes going into the baby so that they don't get hyperventilate. Yet hypocapnia or hypocarbia also reported contributes to detrimental effects such as cerebral vasoconstriction, decreased partial pressures of arterial oxygen, decreased oxygen release from hemoglobin, and excessive brain excitability due to increased oxygen demands. So the goal of this type of ventilation is to control the PCO2 and basically prevent hypocapnia in this population. So in the conclusion of this study, they were looking to control minute ventilation and tidal ventilation using volume guarantee, and they found that the use of volume guarantee ventilation in babies with HIE reduces tidal volumes and frequently results in very low inflating pressures without impacting PCO2. So the point here is they could ventilate the baby effectively and reduce the likelihood of hypocapnia, which actually could create greater concern for HIE patients. Another good reason why to use it. In the final study I'm going to show you, they were looking at the effects of volume guaranteed ventilation when it's combined with two different modes in preterm infants. So what they were looking at is that volume guaranteed ventilation can be used in three different modes. Number one, it could be used in assist control. It also could be used as a pressure support ventilation, PSV, and it could also be used in SIMV. So volume guarantee is not just one particular mode. It's like you use volume guarantee with both pressure support, assist control, and SIMV. And they wanted to know if one is better than another. Is there a best mode? And what they did was they compared pressure support ventilation versus SIMV ventilation, both of them with volume guarantee. And I'll get a little bit more into the findings of that. To get a little bit more into the details of this study, what they looked at was some preterm infants who were born in their hospital between the ages of 24 to 32 weeks of gestation, and they needed mechanical ventilation because of respiratory distress syndrome. So all of these patients who had to be intubated were randomized either to SIMV with volume guarantee or pressure support ventilation with volume guarantee ventilation. And what they looked at, they recorded ventilatory parameters, they looked at clinical data, they looked at blood gases, they also looked at tracheal aspirate cytokine levels, and they wanted to see, was one mode superior to another in regard to volume guarantee? Was SIMV better or pressure support better? They didn't do assist control in this particular study, but we are comparing here SIMV with VG and PSV with VG, and we'll see the results of that study. As I mentioned earlier, the benefits of volume guarantee ventilation versus pressure limited ventilation is the duration of mechanical ventilation, the incidence of BPD, hypocapnia or hypercapnia, severe IVH, pneumothoraces. So there's a lot of benefits, but the question here is not talking about the benefits, but it's talking about which mode of ventilation was better with volume guarantee. Was it SIMV or was it pressure support? And what they found with this study was that pressure support ventilation with volume guarantee provided closer tidal volumes to set value ventilated preterm infants with respiratory distress syndrome. So what they found was that the volumes with pressure support ventilation were more close to what was to be predicted rather than SIMV. So the key point here is if you want to use pressure support ventilation with volume guarantee, it's a safe mode, and you could actually deliver more accurate volumes than if you did it with SIMV with volume guarantee. This is one study, and I'm sure there's going to be more studies to come out. But as you could see from all the studies that I've been mentioning, Everyone talks about how good this mode of ventilation is and how it really helps. I don't know how many clinicians at the bedside are using this mode of ventilation, but I would strongly encourage it. When I used to work at my hospital in Newark, New Jersey, we utilized this mode a lot. So that's the findings on this study. So, in summary, controlling tidal volumes is very, very important with the neonates. You don't want to overly distend the airway. You don't want to underventilate the patient. So you want to give a tidal volume that is accurate and consistent. Because the babies have cuffless endotracheal tubes and because of measurements of tidal volumes, inspiratory tidal volumes and expiratory tidal volumes, it's really important to get accurate measurements. And the new end ventilators really do a great job with that. So the concept of volume targeted ventilation strategies has been shown to be very promising for this population. Volume guaranteed ventilation has been shown to reduce the duration of mechanical ventilation, reduce the incidence of chronic lung disease such as bronchopulmonary dysplasia, reduce the likelihood of getting hypercapnic or hypocapnic, to decrease the likelihood of getting severe intraventricular hemorrhage, decrease the likelihood of pneumothoraces, and so on. So there's so many benefits going along with volume guaranteed ventilation or volume targeted ventilation that you really should utilize. And I think a lot of ICUs have. In our hospital, we used to use this mode quite extensively. And I just wanted to mention one more thing. There are new modes of ventilation combining volume guaranteed ventilation with high frequency oscillator. So that may be a new topic I may come up with, but just to give you an idea of some of the titles out there, they have a title called Impact of Volume Guaranteed Ventilation on High Frequency Oscillatory Ventilation in Preterm Infants, a randomized crossover clinical trial. So here what they're doing is combining the benefits of volume guarantee with the benefits of high frequency oscillator and seeing what the results are. That is to come in the future. But these are where the new research is being done right now on the combination of both modes. But to tell you the truth, you could use just volume targeted ventilation as a primary mode, and you could do great things for the baby. So I'm listing some references here. There are many more to be put out there, but I thought I'd just give you these right now. So all of them speak to the use of volume targeted ventilation. They all speak to the benefits of it. And if you really want to do some more research, I would suggest that you read one of these articles or read them all so you get a better handle for it. So thank you very much for joining my presentation. This is a great time to ask questions. So if you have any questions in regard to this topic, please type them in the Q&A and I'll do my best to answer them. And I want to thank you for joining me at my presentation. I think this really covered it pretty well. And again, thank you and hope to see you again in the near future.